Good morning, everyone, and welcome. We're so pleased to see everyone here. My mother always told me that a rainy day is a sign of good luck, so we have lots of good luck today, and we appreciate your efforts to get through the rain and get to us, join us today. I'm Richard Sorian, the Assistant Secretary for Public Affairs at the Department of Health and Human Services, and it's my pleasure to start things off. We're here to announce the Partnership for Patients, a new initiative designed to bring together public and private partners, patients, doctors, nurses, hospitals, health plans, employers, unions, state and federal government, all together to work in tandem to improve care for all patients and to make our system more cost-effective. Secretary Sebelius and Dr. Berwick are incredibly pleased to be joined by a remarkable group of partners and leaders. I'm just going to briefly introduce them, and then we're going to start off the program. Sorrel King, to my right, is a patient advocate and an amazing leader from Baltimore, Maryland. Dr. Cecil Wilson, president of the American Medical Association. Dr. Patricia Gabow is the CEO of Denver Health. I'm going to stop looking for where they are because they're all next to me. David Cody, the Chief Executive Officer of Honeywell. Deborah Ness, the President of the National Partnership for Women and Families. Mike Fogarty, the Medicaid Director for the state of Oklahoma. And Jerry Shea, the Assistant to the President of the AFL-CIO. With that, I'd like to introduce Sorrel. Thank you very much.
Good morning. Thank you all for being here. It is an honor for me to be here. I'm just going to go right into it. I'm going to tell you something we all know already. 98,000 people die every year from medical errors. Fourth leading cause of death in the country. Like a jumbo jet crashing every day. Now I'm here today because my daughter is one of that 98,000. My daughter Josie died 10 years ago from medical errors at one of the best hospitals in the country, right up the road, Johns Hopkins. And after she died, my husband and I took some of the settlement money and we created the Josie King Foundation. Now, for 10 years, I have been traveling all around the country, in and out of hospitals all around the country. Little community centers, big academic centers, statewide hospital associations. I've been everywhere. And I have to tell you, they are doing really great things, and really great things are happening in this patient safety movement. But I have to tell you, it's not happening fast enough. And as a mother whose daughter has died from medical errors, as a patient safety advocate who has talked to so many other families who've been affected by this, as someone who is in and out of hospitals all around the country, talking to hundreds and thousands of doctors and nurses, we need help. And it's time. It is time to all come together, patients and families, hospitals, doctors and nurses, the government, the insurance companies, businesses. We've got to come together, and we've got to do it, and we've got to do it now. And we cannot keep going at the pace we've been going. I'm sort of a simple-minded person, and it just seems simple to me that if we can make hospitals safer, then we can prevent people from dying. We can shorten hospital stays. That will cost the insurance companies less money. It'll make doctors and nurses happier because they'll be going to a great work environment where the culture is better, where the nurse isn't afraid to be the one who's going to work that day to hang the IV with the incorrect dosage of some medication on the pole that's going to harm that patient. The system's broken. We need to fix it. It's been an interesting journey. I've been doing this for 10 years, and I am so happy to be a part of this today because I hope that this thing is going to get going faster. Now, I'm honored to introduce Secretary Sebelius. This is not new to her. She's been pro-patient safety for a long, long time. And without any further ado, Secretary, thank you so much from all the patient safety people out there and for all of the families. Thank you for all that you do. And I'm looking forward to this new momentum that's going to get going here.
Well, good morning, everybody, and thank you, Sorrel, not only for your willingness to lead this effort. I think we all, as parents, can appreciate the incredible loss that you and your husband have experienced, but to turn that energy into an effort that's going to save millions of lives is really a terrific way to deal with your tragedy. I also want to acknowledge we have a room full of great HHS leaders who have worked on this effort for a number of months, and want to thank them for being here today and also for their leadership in this initiative. Now, there's no doubt that America has the most skilled doctors and nurses, the finest hospitals in the world, and every day countless Americans receive care that's good or better than any in the world. People travel to America from all over the world to get treatment they can't get anywhere else. But we're here today because far too often, far too many patients, we fall short of that high standard. In some cases, Americans go without care because they've been shut out or priced out or locked out of the insurance market. And that's why we're continuing to work to implement the insurance reforms in the Affordable Care Act, which eventually will give every American access to affordable health coverage. But in other cases, people actually make it into the system, and then something goes terribly wrong. Just last week, a report released in Health Affairs found that errors or adverse events occur in nearly 1 out of 3 hospital admissions. 1 in 3. Now, sometimes it's just an improper dose of medication that leaves somebody feeling dizzy or nauseous, but too often, in cases like Josie's, the consequences are far more tragic. And what makes the results even more unacceptable is that we know we can do better. I've seen firsthand some of those improvements as I travel across the country, and just recently I've seen some great hospital systems. In February, I was in Virginia Mason Hospital in Seattle, where they've studied the best manufacturing techniques to learn how to deliver more consistent, excellent care. In the process, they've reduced patient falls by 25% and bed sores by 75%. In March, I was in Ohio visiting with hospital, community, and business leaders, where they've formed a coalition statewide to improve patient care. Already, they've prevented about 3,600 infections and medicine complications for Ohio's children, saved about $13 million in reduced health care costs, and they're just getting going. Now, it's not just those few exceptional health systems doing this. We know that in Michigan, when a coalition of hospitals came together around the checklist from Johns Hopkins, they were able to reduce the occurrence of a common infection by 2/3, cut health care costs by $200 million, and save 1,500 lives in just 18 months. It reminded providers to take some fairly simple steps, but it used leadership in those systems to drive that new protocol. Now, those hospitals have already shown that it's possible to deliver better care, and that's going on in pockets around the country. The challenge is how to figure out how to make these models spread and accelerate this care improvement. And that's why no one could do this alone. America's doctors and nurses are already working as hard as they can, doing their best to take care of their patients. Simply telling them to solve this problem on their own would be unfair and, frankly, unproductive. We also know that a top-down solution where government or employers go to hospitals and tell the healthcare providers how to do their jobs doesn't work either. Now, we've already seen how progress can slow down when hospitals do one thing and health plans do another and Medicare goes in a third direction. And that's really why we're here this morning. Today, we're announcing the new Partnership for Patients that will bring together hospitals, physicians, nurses, employers, unions, patient advocates, health plans, and others to improve the safety of healthcare in America. Our ultimate goal is one that was shared with me by one of the doctors I spoke to at Nationwide Children's Hospital in Columbus, Ohio. He told me that they don't strive to reduce harmful errors for the children they treat by 20% or even 40%. Their goal is to eliminate errors altogether. That has to be our aim too. Now, to get started, we're setting 2 ambitious goals for the next 3 years. First, we're committed to reducing preventable injuries that happen in hospitals by 40%. That would prevent 1.8 million injuries, and saved 60,000 lives across this country. Secondly is to cut preventable hospital readmissions by 20%, saving more than 1.6 patients from complications that force them to return to the hospital. Now, to achieve those goals, we've reached out to hospitals, physician and nursing organizations, patient advocates, health plans, and major employers in this country. And today, I'm pleased to be joined by representatives of a few of our partners. We already have more than 500 hospitals who have stepped up to say we want to partner in this effort. And in the months to come, we know that number is going to grow. Now, if we are able to succeed, we need everyone's contributions. But Medicare has a very special role to play. As the source of health insurance for more than 45 million Americans, Medicare has a deep responsibility to help improve the quality of care. And as the country's largest payer for care, Medicare has a powerful ability to be a catalyst for change. And that's why we're announcing today that we'll commit up to $1 billion in new funding from the Affordable Care Act toward those two initial goals. In addition, we're providing hospitals and physicians with an unprecedented range of resources about what other healthcare providers are already doing to improve patient safety. This is not just about improving health, but by reducing medical errors, we're also going to bring down rising health insurance costs, which have put a growing burden on families, businesses, and government. And every time a patient gets an infection in the hospital or is readmitted because they didn't get the right follow-up care, our nation's health care bill goes up. And that's why it's estimated that reaching those targets that I've just announced today would save up to $50 billion across our health system over these next 3 years, up to $10 billion alone for Medicare. So this is going to impact costs for every family, every business, every individual in America. That's a return for up to $10 for each dollar we're investing. And critically, this is just one part of a broader agenda to support the efforts of doctors and nurses to improve care through the health care law. Last week, for example, we proposed rules that will help healthcare providers form accountable care organizations, making it easier for doctors and nurses to work together to keep their patients healthy. We're also working through the new Innovation Center in Medicare and Medicaid to test additional models for improving outcomes on reducing costs. In the coming year, we'll begin to tie hospital payments to quality results to reward those that deliver the best care. What these reforms mean for healthcare providers across the country is that they've never had more support as they continue their work to improve safety for their patients. By assembling this partnership and committing to these ambitious goals, we're sending a clear message that we can no longer accept a healthcare system in which only some Americans get the best possible care. We know that the type of change we're talking about today won't come easily, and we also know that it can be done. And I look forward to working with our partners across this room and across the country to work toward the day when no patient has to go through what Sorrel and her husband did ever again. As we move forward, we couldn't have a better person guiding this effort than Dr. Don Berwick. President Obama chose Don as the administrator of the Centers for Medicare and Medicaid Services, but I've got to tell you, he is the right person at the right time to lead this critical initiative. Don and I met each other in the late 90s when we worked on the Clinton Health Commission working on patient safety issues. He has been leading a national effort on this since then, and we are so delighted to have him as our leader today. He's a great friend, a great partner, a great leader, Dr. Don Berwick.
Thank you so much, Secretary Sebelius, and for your leadership overall. We're launching the Partnership for Patients because too many Americans are being harmed by the care that's supposed to help them. In a report last October, the Inspector General found that 1 in every 7 Medicare beneficiaries is harmed in the course of their care, and almost half of those harms are preventable. This doesn't just produce anguish and tragedies for families and patients. It wastes over $4 billion of Medicare money every year. Among chronically ill adults, 22% report a serious error in their care in the previous year. And as the Secretary said in an article in Health Affairs just a couple of weeks ago, we raised the stakes by finding a report that the number of adverse events in hospitals could be 10 times greater than we had originally thought, injuring as many as 1 in every 3 hospital patients. As stunning as those rates may be to some, I actually suggest that they're not actually that surprising. Let me ask you a question. How many of you here, if you think about it for a minute, know of a friend or a loved one, or maybe yourself, who has been injured by care with a complication, an error, something that went wrong, something that made you wonder, how could that happen? If you know someone who's been injured, or yourself, could you just raise your hand? Almost every hand's up. This is not a rare event confined to someone else. It's about us all. Now, this isn't, I repeat, it is not to call into question the goodwill or the commitment of the healthcare workforce. As the Secretary said, we have the best trained and best equipped healthcare workforce in the world. When it comes to patient safety and effective care transitions, the workforce is not the problem. Doctors and nurses and pharmacists and all other healthcare staff and managers, they want to offer safe care. They learn first, do no harm. That's the first lesson in their training. And that's what they try to do every day. Our healthcare people come to work every day to do everything they possibly can to place patients on the road to health and to keep them on the road to health. But still, despite that, millions of patients get injured, not because of the workforce, but because of defects in the care system in which those good people get trapped, the good people who do the work. Good people get trapped in bad systems. In fact, actually, the heroic efforts of doctors and nurses and pharmacists and others, they're the last dike against the problem. They often protect us against even worse rates. This burden is not inevitable. We can, over time, just about eliminate many, many types of patient injury. And the way to do that is to improve the care systems, to allow the doctors and nurses and others to do what they desperately want to do, which is to give safe care. Blame and accusation are not the answers. Teamwork and improvement are the answers. Commercial air travel didn't get safer, and it's very safe, by exhorting pilots to please not to crash. It got safer by designing planes and air travel systems that support pilots and others to succeed in a very, very complex environment. We can do that in healthcare too. We have lots of examples of that already as in hospitals throughout the country that have driven different kinds of patient injuries close to zero. Bloodstream infections from IV lines, pressure sores for patients who are in bed for a long time, pneumonias that people get when they're on respirator machines. The CDC last month reported a 58% decline in this country in ICU central line bloodstream infections. And Centara Norfolk Hospital tells me they went 5 years without a single case. That's clear evidence of what hospitals can do when they get focused, when they learn from each other, and when they benefit from better aligned incentives. It's the same for readmissions. A project in Denver, Colorado that assures seamless care from hospital to home has cut Medicare readmissions there by 9.3%, part of a 14-city demonstration that has already saved over $100 million by providing better care. Every single time, we find at the heart of these successes commitment and leadership from clinicians, doctors, nurses, pharmacists, and others, and from hospital leaders, boards of trustees, executives, and clinical chairs to help make these changes the norm. Improving patient safety may look easy at first. Why not just use a checklist? Why not just wash your hands? But trust me, even these apparently very simple changes, they can be very, very tough to accomplish in today's busy, hectic, pressured, complex hospitals and clinics. It looks easy, but it's not. And because of that, the Partnership for Patients will be reaching out, public and private partners together, to help hospitals and their staffs learn how to make care safer and to adopt the best known practices as quickly as they possibly can and to adapt them to their local circumstances. One size doesn't fit all. The Partnership for Patients, as the Secretary said, are going to keep patients from getting injured or sicker. By the end of 2013, we will reduce preventable hospital-acquired conditions by 40% compared to now. Helping hospitals heal without complication. By the end of 2013, preventable complications during transitions being reduced so that hospital readmissions would fall by 20% by 2013. Those are big goals. Achieving those goals are going to require a lot from all of us. But it'll require three things in particular, if I can focus you for a moment. First, we're going to need will. We're going to need to decide to do this. That's going to take awareness of the problem, even more awareness now among the public and providers, and it's going to mean building and tending very thoughtfully, very respectfully to incentives for change, like measurement and transparency and payment, and when we need to, regulation, incentives that are largely structured into the Affordable Care Act. The second thing we need is we need to learn together. We need to find and share the very best ideas about how to make care safer. We need to exploit and copy a steady stream of successful models of change that hospitals and communities all over this country can learn from. And the third thing we need is to execute at full scale. We need to make major investments in helping hospitals and clinicians to translate the improvements in care into their own local actions. It will be very hard work for them to learn, adopt, and then adapt the new and reliable practices across their systems, and we need to help them do so, and we're going to make those investments. Combined support from the CMS Innovation Center of as much as $1 billion, along with ongoing departmental efforts to improve safety and care, are going to help fuel this change, helping people find and learn and adopt new practices. We'll focus first on a set of well-established, evidence-based interventions that are known to reduce harm to patients and to reduce preventable readmissions. We're also going to sign up a group of advanced participants, pioneers, organizations that are willing to measure and tackle not just a list, but all forms of harm and complication, not a short list, all forms. Participants that are willing to transform themselves into the overall safer, high reliability organizations that healthcare can become, that ought to be our future. There's a central theme, there's a central question that underlies all of this effort. The question is this: if there, why not everywhere? If Seton Austin can go 10,000 deliveries with only one single case of perinatal injury, why can't everyone? If Ascension Health can reduce pressure ulcers throughout its system by 95%, why can't everyone? If Nationwide Children's Hospital in Columbus can reduce surgical complications by 60%, which they have done, and so on and so on and so on, why can't all Americans benefit in life and health and security from the very best care known to any American? Why not bring excellence to full scale? That's what this is about. And as the Secretary said, we are in this together. We have to be in this together. None of this will happen without us staying together, and especially without the serious commitments of leaders, boards, clinical leaders, executives in all hospitals and systems. And it won't happen either without the energy and the commitment of, I think, literally all the major stakeholders in healthcare. The people you see here with the Secretary and me: consumers, plans, employers, providers, and others. It won't happen with other government agencies besides HHS. I see our colleagues here from the Department of Defense Military Health System and the Veterans Health Administration. We're in this together. I think we're there at last, where Sorrell asks us to be. We have reached out to dozens of stakeholders and organizations. Everyone has stepped up. I've been working on patient safety for the better part of 20 years, and I haven't seen anything like this before. It's thrilling. And we can do this. Now, I want to take one more minute to place this in a slightly broader context. I think America is facing a really important choice right now as we struggle for a care system that we want and that we need and that we can sustain. The options are two: either to cut care or to improve care. I am against cutting. I am for improving. And if you know the facts, improvement is the best way, it's the only right way to get to the care we want for ourselves and our children. Healthcare, in this regard, is just like any other important segment of our economy. Doing it right, in the long run, costs less, and it helps more than doing it wrong. Computers today do more than they ever have at far lower prices. The same is true for cars and TVs and telephones, just about any other product or service that we really care about. And they didn't get there by cutting or by rationing. They got there by improving the processes that make their products and services. And it could be the same for healthcare. Improving quality is the right way. It's the best way out of our healthcare conundrum. We owe that to ourselves, and we owe that to posterity. And safety for patients is the cutting-edge goal for improvement. It's the flagship. It affects every one of us. Look at how many hands went up. It unites us against a common enemy. The enemy is not each other. The enemy is harm itself. And it is right in the sweet spot of what we in CMS are now calling the three-part aim: better care for individuals, better health for populations, and lower costs through improvement. Safety for patients is on the golden line toward our healthcare future. It's right, and its time has come. So let's get started right now, everyone together. With that, let me introduce one of the representatives of among the most essential of the partners in the Partnership for Patient Safety, physicians. With me is Dr. Cecil Wilson, the president of the American Medical Association. Cecil.
Well, thank you, Dr. Berwick, and thank you and the Secretary for the leadership you're providing in this really important and, let me just say, exciting initiative. My name is Cecil Wilson. I'm an internist from Winter Park, Florida, and president of the American Medical Association. And I am pleased to be here today to help announce the launch of the Partnership for Patients, a patient safety initiative that is focused on keeping patients from becoming sicker and helping patients heal without complication. Throughout this voluntary, goal-oriented initiative, physicians will be encouraged to do everything they can to reduce adverse events and reduce readmissions. For instance, we know that if we ensure that a patient's primary care physician receives their discharge papers within 24 hours of their release from the hospital, the likelihood of a hospital readmission will be reduced. Improving the quality and safety of health care has been a guiding principle for the AMA since its founding in 1847. The AMA is working to improve patient safety through our Making Strides in Safety program already, which provides physicians with patient safety materials and point-of-care tools. And we partnered with the Institute for Healthcare Improvement to help improve outcomes in hospitals through system improvements. The AMA is proud to continue to promote a culture of patient safety by joining the Partnership for Patients. We all need to do everything we can to avoid preventable patient illness and injuries, while also working to ensure patients are able to heal without complications. Now, as you've heard from Dr. Berwick, physicians work hard every day to provide excellent care to patients, and they need the best systems in place to support them. Our hope is that this initiative will improve hospital care, improve the health of individual patients, and reduce the cost of health care by improving quality. As physicians, we look forward to joining other healthcare professionals to advance the work that's already been done to achieve safe, high-quality care. And we are pleased that the government is joining us in the commitment to improve patient safety by designating a significant amount of funding toward this initiative. In particular, a portion of this funding will be used to create tools that physicians can use to help achieve the goals of Partnership for Patients to improve safety and continuity of care for patients. So the AMA is proud to be a part of this partnership, and we as physicians look forward to working with leaders of hospitals, employers, nurses, patient advocates, along with state and federal governments to make hospital care safer, more reliable, and less costly. Working together, we can ensure the right care for the right patient at the right time. Thank you, and now our next speaker is Dr. Patricia Gabau.
Good morning. This is a red letter day. and I'm honored to be here to endorse this initiative and affirm Denver Health's commitment to patient safety and quality. Denver Health is an academic, integrated healthcare system and Colorado's principal safety net institution, providing $382 million of care to uninsured people last year, and the state's largest Medicaid provider. We care for 1 in 3 people in Denver and 40% of Denver's children. Like most American healthcare systems, we espouse quality and safety, but also, like most, we have learned that aspiration alone will not produce safety and quality. Our integrated system, our employed physician model, and robust information technology provided a foundation upon which to build. 7 years ago, we began a structured approach to safety and quality, which included creating a comprehensive approach to patient care, appointing a person and a department with primary responsibility for quality and safety, creating programs to manage high-risk clinical situations, and implementing systems to reduce variability in care. The adoption of Toyota Production Systems, or Lean, is an important part of our comprehensive approach to care. Lean tools and lean concepts of standard work are applicable to patient care. For example, one of the common and potentially fatal hospital-acquired conditions is deep venous thrombosis and pulmonary embolus. In other words, clots in the legs that break loose and end up in the lungs. Using Lean, we have now achieved one of the lowest rates of this complication and reduced costs by $15,000 per month, demonstrating the link between safer care and lower costs. Safety includes freedom from harm and from the risk of harm. Therefore, we developed approaches to high-risk clinical situations. We all know about hospital-acquired infection, but many assume that preventing infection involves using lots of antibiotics. But antibiotic overuse is a big problem. So we created a program to guide their use in our hospital. As a result, our use of antibiotics is extremely low. That has reduced our antibiotic-resistant organisms, the complications from antibiotic overuse, and costs by $200,000 per year. This structured approach made our care safer. We have the lowest observed to expected mortality among 112 academic health centers. To translate that statistic to real life, more than 200 people walked out of our hospital alive who would have been expected to die last year. We are now safer, but we are far from perfect. That is why we are committed to keep up this effort and why we're standing here today. Thank you. Now let me introduce David Cody, the CEO of Honeywell and a passionate leader about patient safety from the employer community.
We're proud to support the Secretary's initiative to improve the likelihood of quality outcomes for patients. As business has demonstrated in various industries over the last 3 decades, quality costs less, not more. If we're successful in this effort, we can have better patient outcomes and lower costs. And I have to say I was particularly struck by Dr. Grabow's comments on the Toyota Production System. It is applicable, and we've been applying it across our company, and the results are just astounding in all kinds of different industries, and I don't see why this industry would be any different. So I completely agree with her. We believe significant potential exists to spread best practices more effectively across this industry. Getting back to some of Sherelle's comments, the Institute of Medicine estimates that there are as many as 100,000 deaths per year attributable to preventable medical errors in hospitals. Now, to put this into perspective, that's more deaths than auto accidents, AIDS, and breast cancer combined. Yet it gets nowhere near the attention that it should. With process analysis tools, the appropriate use of statistics, quality comparisons, and information technology that supports rapid dissemination and implementation of best practices, we could have a far more effective and less costly delivery system. It's easier today to get detailed quality data on purchasing a new car than it is to get quality data for a hospital where you have an operation that will have a significantly greater impact on your life. Now, some of you will think that depends on what kind of car it is as you make your own decision, but I think most of you will end up agreeing with me. As a company, what we would like to be able to do is differentiate our payments based upon quality performance. So, for example, an employee going to a high-quality hospital would get reimbursed at, say, 80%, while a similar operation at a low-quality hospital would be reimbursed at 40%. This would encourage high-quality hospitals to thrive and our employees to receive better outcomes. It'll start with metrics, and that's always tough because, as we've observed, if you measure something, the metric will get better. It doesn't mean anything actually got better, but people and organizations learn to adjust to how they are being measured. What it does mean is rapidly moving through the metric definition, gathering the input while resisting all the howls of protest that will come regarding unfairness, and that'll stymie that first essential step. It doesn't mean rushing. It does mean don't let the process incapacitate a decision. Then it requires implementation along with some kind of audit mechanism or process to ensure it's done correctly and consistently. It's an essential part of the process to ensure that the metric isn't the only thing getting better. In other words, that fundamental processes and outcomes are also. This baselining with consistent metrics will create a great format for implementing recognized best practices and actually seeing the results. I'm not saying all this is easy. I am saying that business has taken this approach for years now with quite effective results as processes are improved. We strongly support the Partnership for Patients initiative, believe lots of good can come from it. We've been working on implementation of the Toyota production system. People and process are something that we spend our lives doing. We're willing to help in any way we can. If Dr. Berwick, if you'd like to conduct best practice visits with us, we're happy to do that also. But we think this could be huge. Thanks.
Well, as you can see, we have some great partners who were speaking today, but others in the room on this really critical initiative that is aimed at improving health, lowering costs, and saving lives. And there couldn't be a better mission to launch on. So with that, I would open the floor to questions if folks have questions for us. Yes. Oh, yes.
I am Penny with CNS News for Administrator Berwick. Administrator Berwick, you said 40% reduction by 2013. Can you be more specific on how you plan to accomplish that?
Sure. It's 40% reduction in hospital-acquired conditions, a list of complications that patients face and that we know can be reduced. In almost every single case of those conditions, we know places in the country that have knocked the socks off the problem. They've actually reduced, in some cases, eliminated those. The problem is that knowledge doesn't move around quickly enough. So a mainstay idea is learning. So that part of the resources that we'll be investing will be setting up networks of support to reach out to hospitals and clinicians and leaders so that they can learn who's doing the best and what the best looks like and how to adapt and adopt it locally. That can't be done centrally from Washington. There'll have to be a distributed system of such kind of technical support. That's important. It's important also to notice the alignment of incentives here. The Affordable Care Act downstream begins to align incentives very strongly on this, and so the hospital's attention is going to be focused very much on this, and we'll capitalize on that attention in order to help them learn and adopt what's needed. There'll also have to be investments in leadership development and energy. Boards of trustees, clinical leaders, executive leaders will need an opportunity to engage in dialogue, introspection, consideration, and because in the end it will be their decisions and their willingness to invest corporate strategy, organizational resources, and support in this effort that will spell a success. It's a large-scale outreach, one of the largest we've ever seen.
A question for Dr. Berwick, John Reichard with CQ Healthbeat. You're known for your previous 100,000 Lives campaign. Is this, are these lives saved, added 60,000 lives in addition to the 100,000 lives? How does this campaign compare? Is it completely separate from the previous campaign?
There have been a lot of campaigns in the country, and we've learned a ton from watching the efforts both in my prior organization, the Institute for Healthcare Improvement, but also the Secretary's been leading an initiative on infection and infection reduction. We've seen corporate efforts in Premier, Ascension Health, other large systems. I think we're combining all that information now, and now that we understand what these networks of support look like and what kind of results can be achieved in pockets, I think we can go for this at a national level. And yes, these will be additional lives saved to the current efforts.
Janet Adamy from the Wall Street Journal. I have a question for Secretary Sebelius. You mentioned the role that Medicare plays in being a force of payment shaping and quality shaping in the health system. There's a House Republican proposal to effectively end the Medicare program by switching seniors into basically a voucher program. What do you think of that proposal, and overall, what kind of impact would that have on patients?
Well, I think, Janet, there has been a lot of attention in the first year of implementation of the Affordable Care Act on some of the insurance market changes that came into effect in 2010, and a lot of work on that. What is less well known, I think, to a lot of Americans is the enormous effort and emphasis on delivery system changes and using Medicare's vast network of providers and payments to actually become a value-based purchaser and help join what have been often employer-based efforts and insurance-based efforts to get at the underlying healthcare costs. What people keep saying is, you know, what about the rising costs of healthcare? This is exactly where we're going to improve care and actually lower costs along the way. The details that I've at least seen so far of the House Republican budget proposal, which would provide vouchers for Medicare, do nothing to address underlying health costs. And in fact, I would say it's a massive cost shift from the initial analysis that I've seen. What it does is shift enormous amounts of healthcare costs to seniors, not addressing the care improvement, not addressing cost increases, but actually having seniors pick up larger and larger share of their own costs. The voucher for approximately $8,000 is less than care delivered a couple of years ago, and yet that would be effective in 2022 when arguably costs would have continued to rise. So seniors would have approximately 68% of their health care out of pocket at that point, based on today's estimate. So I think what we're talking about really is working with the health system to not only improve care for all Americans, but actually lower costs, address the underlying costs, and do that both through the prevention efforts. You start with a healthier population, so looking at the 7 out of 10 deaths that come from chronic disease, and looking at smoking and obesity particularly that are driving a lot of those chronic disease conditions. And those preventive efforts are a key part of this puzzle, but also working with delivery system changes and using, as I say, Medicare's efforts as an accelerator. What I hear often from the private sector leaders is that Medicare was often a drag. Folks, whether it was insurance companies or employers, wanted to invest in quality improvements, wanted to move in one direction, and Medicare was a volume purchaser. The more you did, the more you got paid. So this is an enormous shift in a direction that will help us not only improve care, but lower costs by that care improvement and save lives along the way. Like Sorrel just described, no parent should have to dread taking your child to a hospital and have that situation occur. So we think this effort is enormously helpful. Yes, ma'am.
Jessica Zigman with Modern Healthcare. This question is either for the Secretary or Dr. Berwick. Can you tell us a little bit more about...
How hard is it? I'll decide who gets it.
Regarding those demonstration projects, when do you expect to begin the application process, and how many are you expecting to accept?
Excuse me, could you clarify the demonstration projects? For the advanced group, the pioneer group, as soon as possible, we have the plans are in place. They're going through clearance and review right now, and I suspect very quickly we'll be able to ramp up that edge of the project where there'll be a vanguard group who will go for all-cause harm with respect to setting up the infrastructural supports to help all hospitals tackle the hospital-acquired conditions and readmissions. Again, I hope within the next couple of months we'll be up and running seriously. There's already a lot of energy, and we'll be capitalizing on that.
This is Jim Arvantis, AAFP News Now. You talked a lot about hospitals in this initiative, and I wanted to know what role will primary care play in this initiative going forward?
Well, let me take a little crack at that, and then I'd like Don to address it. And actually, what Dr. Gabot has done in Denver Health is really wrapping a system around, I think, care providers. First of all, let me make it clear that this is not about hospitals being the bad guys. Nothing could be further from the truth. I think people are receiving excellent care in health systems across the country. It's why people travel from all over the world to access care here. What we know, though, is with systems approaches, using some of the techniques, as David Cody and others have said, that are in place in other industries, we can help systematically re-engineer care improvement and have backup and fail-safe systems that really just aren't in place. I don't think there's any question that whether it's with care delivery in a hospital setting or certainly with the secondary goal of the hospital readmissions, a primary care provider becomes absolutely critical in this puzzle. Hopefully we, again, keep people healthier in the first place so that they may access hospitals less frequently with more preventive care, again, built around primary care system, which is why the Affordable Care Act has models like the medical home model and care in place models. But when a patient is released, having care providers in touch with the patient, the bundled care strategy, which again is a payment initiative in the Affordable Care Act, some of the care models that we know, follow-up on patient care, can dramatically impact that readmission number, and that's one of the goals. But primary care providers and I would say, the tools that are going to be in place and are beginning to be realized with the move to system-wide health information technology. I mean, part of what we've been missing for a long time in this country is actually a system-wide adoption of electronic health records, being able to share in a real-time basis information about, you heard Dr. Wilson talk about getting the file to someone within a 24-hour period. Well, ideally, that file could be accessed instantaneously. You wouldn't have to wait even 24 hours to know what was happening. You'd know that the right prescription had gotten to the pharmacist at the right time. You'd be able to monitor whether or not that prescription was filled. So the health information technology through the Recovery Act investment that's beginning to take hold in this country is a critical piece of this puzzle, not only measuring what we're doing, but then monitoring and being able to follow that protocol wherever the patient is, that care could be accessed and delivered. Do you want
to? Primary care is essential, and especially with respect to the readmissions, the Secretary said there's a lot of focus in the Affordable Care Act and other things that are going on, and in this project, about half of their sources are coming from a care transition project. So we're going to see this as a systemic enterprise. But your question invites zooming out for a moment and looking at this overall safety effort in the context of what I think is now the era of healthcare delivery improvement. That's what this is about, and it's a very important, charismatic, and crucial piece of it, but it's only a piece of it. And if you look at the overall terrain the Secretary talked about, accountable care organizations, the wonderful possibilities and programs that will emerge from the Innovation Center, the new focus on dual eligibles, the Federal Coordinated Care Center, value-based purchasing, transparency, and investment in kind of daylight, so we can see how care is performing, as Mr. Cody talked about, bundled payments, medical homes, health homes, in the pediatric area. I see Judy Poffer here from the American Academy of Pediatrics. There's a lot of possibilities in the pediatric arena, and that's mostly going to be in the outpatient sector. The electronic health records affect us all. This is a suite of changes. It's America turning its attention toward recreating the healthcare system we all really want and need. Safety is the flagship, but there's much, much more to do.
I'm Donna Smith with Reuters. This is for Secretary Sebelius and Administrator Berwick. Some recent high-profile cases and a new lawsuit involving some hospital groups would suggest that the incidence of fraud and abuse in Medicare is much higher than people would normally think. Can an initiative like this get at that issue of reducing abusive practices as well as outright fraud?
Well, I would say this particular initiative is really aimed at patient care and patient safety, but there's no question we have a very new set of tools, new set of resources, and new leadership looking at fraud and abuse in the healthcare system. That has always been a concern, but we finally have a deputy administrator in the Centers for Medicare and Medicaid Services who is exclusively focused on fraud and abuse efforts. We are doing an enormous amount given the new tools in the Affordable Care Act, which I would suggest is one of the toughest anti-fraud laws ever passed and gives us sweeping new tools which we really didn't have, everything from re-credentialing various providers in high-risk areas to actually being able to delay payments using prescriptive modeling techniques that credit card companies use. We've always been on the pay-and-chase model, so money goes out the door and you try to catch up with the bad guys at some point along the way. Often they're gone. This actually gives us an ability to build a system to stop that in the front end, prevent fraud. We're never going to prosecute our way out of fraud. We've got to build some much tougher firewalls. So I would say that's definitely a part of this new effort. Again, I think the Affordable Care Act has parts and pieces that too many people are not aware of and are essential to lowering costs, going after fraud and abuse, making sure that criminals aren't stealing from the Medicare trust fund, from the Medicaid system, is a critical part of lowering overall health care costs, and we're working closely with the private sector to do that.
My question is for Mr. Cody. You talked about incorporating differential payments into your employee health benefits. How soon would you be able to do something like that in your negotiations with whoever your health plan provider is, and then the hospitals in your networks? And second, how will you balance the need to provide access to enough hospitals for your employees that it's easy for them to get care, with setting up to encourage them all to go to the higher quality facilities?
Yeah, I guess getting back to the beginning, Getting back to the beginning, we're big believers that quality improves outcomes and reduces cost. So that's kind of the fundamental premise that we start with. As we started trying to understand how to do this, and we've actually been trying to sort out how to do something like this for about 8 years now, the data is pretty sparse when it comes to trying to understand what is a good hospital, what is not a good hospital. And they can differ even when it comes to the operations that they do. And it's really difficult to even get that data. So that's the concept we'd like to get to. Some of the questions that you've raised are the ones that we will confront at some point. What if there are 4 hospitals in a region and none of them are particularly good? We're going to have to think about what decision do we make then? But for now, I'm hopeful that with the effort that's being launched here of those 4 hospitals, by the time we get there, 2 or 3 of them will be very good. And it'll be a much easier thing for us to sort out. So we haven't figured out exactly how we're going to do this yet. But I do know it's the right track to be on, because you can't keep supporting businesses, plants, hospitals, anything that doesn't produce a quality outcome. It just doesn't make sense.
I would just add that a couple of new transparency tools, starting I think later this year, there will be an ability to link the data on hospital-acquired infections to the hospital-compared data. So that will be transparent. It will be available to business owners, to patients, to patient advocates and providers. In addition, again, the platform of the Affordable Care Act is for Medicare to begin paying the kind of incentives that Mr. Cody referred to by 2015 based on some quality outcomes. So that will become a part of the overall Medicare payment, and I would suggest, again, offers an enormous incentive to move in a very new direction that's never been part of the overall platform, and that is built into this system, so that this is not only aspirational and inspirational. I think we've got some real financial incentives that will be part of investments at the front end, a lot of technical help and assistance, a lot of support, a lot of encouragement, sharing best practices, but ultimately a payment system that, again, will measure quality outcomes and reward those who are doing the best job. Thank you all for being here today. I look forward to working on this exciting initiative.